We have a short agenda, so I don't know, we may be done early today. I imagine we will, unless something happens, but we will get started. Kristen is our other coordinator for the Care Hub. She's the Community Connections Coordinator is her title. And she's been asked to, she has a history with working with children. Like, what's your background?
Primarily in foster care and adoption. I worked with the Court-Appointed Special Advocates Program. I was the program director, and also with the Michigan Adoption Resource Exchange.
So, Lori asked Kristen to talk about adverse childhood experiences, ACEs. Is the S for study? ACEs? It's just ACE.
The little s is to study.
Okay. So, I'll let you, do you want me to click or do you want to sit here?
You can click, okay. Yeah. I don't need another thing
to do.
Okay. Okay, so I'm just going to do a little disclaimer. Like, I'm not totally versed in ACEs. It is sort of a passion of mine, and I do have a background, and so when the study came up, I've been following it and going to trainings about it, and so of course you talk enough about something and your boss is going to ask you to do a presentation about it, so that's why I'm here. So I did give everyone here flyers that you're welcome to follow along with, but then I also did put it into a PowerPoint. I'm not sure how well you'll be able to see it on the screen for the meeting burner, but I hope you can at least try to follow along. So as Caitlin was saying, on the truth about ACEs is adverse childhood experiences. And there are 3 different types of ACEs. There's abuse, which would be physical, emotional, or sexual abuse. Neglect, which would be physical or emotional neglect. And then different household dysfunction. So mental illness, the mother being treated violently in the home, going through a divorce, incarcerated relatives, substance abuse. Those are just some examples of it. So it's kind of funny because when Caitlin said that I had a background in it, I thought she was like talking about the fact that I had ACEs. And then later we'll go through and kind of count our own ACEs too, so that you can see that, you know,
it's very common.
It is very common, and a lot of times when you go through trainings like this and you actually do your own ACEs score, a lot of people have at least a couple of them. So this study showed the prevalence of ACEs, and you guys can kind of go through and see the percentages. But out of the 17,000 ACE study participants, 64% had at least one ACE. And then if you look at what the impact of the ACEs have, obviously the more ACEs you have, the more the increase in the negative health outcomes. So the possible risk outcomes are broke down into behavior and physical and mental health. Behavior, so things like lack of physical activity, smoking, alcoholism, drug use, and missed work as an adult. And then with physical and mental health, things like severe obesity, diabetes, depression, suicide attempts, STDs, heart disease, cancer, stroke, COPD, and broken bones. So again, a lot of things that we see in our work with CHWs going out and through the hub. Okay, I have just a quick little 5-minute video to kind of explain it maybe a little better than I could. This comes from, this is the primer for the Resilience movie, if you haven't had a chance to see it. It's a great movie, and currently they're doing screenings throughout the state of Michigan. They have a website you can go to check out where the screenings are.
So that's not a link, right?
I think it is a link, but you have to actually
be in it.
The slideshow. I gave you the link also.
Yeah. Oh, there we go. It wasn't. Hold on. No. I'll go to the link.
This is why I didn't do the PowerPoint, because I always mess it up, so I'll just let Caitlin do it.
You sent me that.
I know I sent it.
It's just on YouTube, right?
Yeah. Just search ACEs primer.
Okay. This is it?
It is. Hit that one.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
All right, so kind of just an overview like I was just talking about. The next slide is the actual ACEs questionnaire, so I thought I'd give you a minute. You don't have to show everybody, and we're not going to ask how many you have, but we'll just go through them just so that you can see what your ACEs score is. So the first one, did a parent or other adult in the household often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? Number two, did a parent or other adult in the household often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? Number three, did an adult or person at least 5 years older than you ever touch or fondle you or have you touch their body in a sexual way, or try to actually have oral, anal, or vaginal sex with you? Number four, did you often feel that no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? Number five, did you often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you, or your parents were too drunk or high to take care of you or take you to the doctor if needed? Number six, were your parents ever separated or divorced? Number seven, was your mother or stepmother often pushed, grabbed, slapped, or had something thrown at her, or sometimes or often kicked, bitten, hit with a fist, or hit with something hard, or ever repeatedly hit over at least a few minutes or threatened with a gun or knife? Number eight, did you live with anyone who was a problem drinker or alcoholic who used street drugs? Number nine, was a household member depressed or mentally ill, or did a household member attempt suicide? And number 10, did a household member go to prison? So all you do with that screening is add it up, and however many of them you have is your ACEs score. Any questions on the screening or so far? Okay, the next slide is understanding the effects of trauma on health. And I'm not going to read the whole thing to you, but one of the most important points I thought from this slide was people who experience trauma time and time again, as a child, even into an adult, get that sort of fight or flight response going. I think probably a lot of us have kind of heard from that just from the field that we're working in, especially people who work more clinically. And so people who have this trauma over and over again kind of stay in this fight or flight response and are always kind of reacting to things in that way, always kind of in fear of what's going to happen next, even if it's not necessarily something that is a threat to them. This slide also touches base on protective factors. And so it's important to know that just because children are exposed to these ACEs, there are protective factors that can help them so that maybe their risk isn't so great of having these health effects as an adult. So things like parental knowledge of child development, healthy parent-child attachment, social connections, and social and emotional competence. The back side of the handout is just sort of another overview of things that we had been talking about. And it starts to really talk about some of the things that healthcare providers can do to help patients heal from trauma. And some of these things may be things that we can also do. They talk about trauma-specific treatments such as prolonged exposure therapy, seeking safety, and the trauma recovery and empowerment model. And so obviously we're not doing those things as CHWs or through the hub, but those are things that maybe we can get them connected to through counseling. They also talk about some policy changes, in particular value-based purchasing and integration of primary and behavioral health care, which may support trauma-informed care implementation. And I know that that's something that we hear about right now really is getting the primary care and behavioral health put together. I know that's something they're doing a lot with community mental health in Ingham County, and I think across the state right now. The next, that's just the end notes, but the next slide I included is the first 1,000 days, Medicaid's critical role. And I found this and I thought it kind of was relative to what we do because we're working with Medicaid eligible and Medicaid adults and some children depending on which county we're in. But it just talks about the fact that, in the first 1,000 days of a child's life, it's so critical in their development, and that Medicaid really touches base with these kids who are at risk, age 0 to 3, and these low-income families, and they're able to reach them, right when it is such a critical point in their development. And it talks about maximizing Medicaid's window of opportunity by integrating data across sectors, using data to target the highest risk children and families, identifying assessment tools and shared metrics, building state and community partnerships, and creating new clinical models and community linkages, which by golly, I feel like those are all things that we have done or are still trying to do. The next slide is key ingredients for trauma-informed care, and again, I'm not going to read all of this to you, but I did want to point out the key ingredients, and after reading this, you will see that a lot of times we do focus on trauma-informed care for people who work in a clinical setting with people, but maybe we're not quite there yet in an entire organization. And so key ingredients as far as clinically, they say involve patients in the treatment process, screen for trauma, train staff in trauma-specific treatment approaches, and engage referral sources and partner organizations. But then organizationally,
Sorry to interrupt. Are there supposed to be slides going? Because there's still a video showing.
Oh, really?
there
Gosh.
were. Did it just freeze?
It must have froze.
And would you just maybe email me the slides
Yeah.
after this?
Yes, I will.
And I'll be able to use them. That'd be great.
Yeah, they are good resources. They're all from the Robert Wood Johnson Foundation because they did take the ACEs study and kind of move it along a little further, so it is good reading.
Can you see the slides now?
Yep.
Okay. Sorry.
That's okay.
I'll send you the handout in a little bit. Not right now.
Okay, and then as far as organizations, things that they can do to be more trauma-informed, lead and communicate about the transformation process, engage patients in organizational planning, train clinical as well as non-clinical staff members, create a safe physical and emotional environment, prevent secondary traumatic stress in staff, and hire a trauma-informed workforce. So I wanted to take a second, since I know we have kind of a variety of different roles listening to the presentation, but kind of think within your organization, do you do any of these things? Or are you working towards doing some of these things? So just take a minute to talk amongst the people in your organization. Okay. So, did anybody come up with some things that you may already be doing within your organization? Trainings? Okay. Like, did you do training specifically on ACEs or more just like trauma?
So we have, obviously, this presentation today.
Yep.
Some of us in leadership have been to other trainings as well. And then I think in December, we're bringing in someone to talk to all of our staff at the
Okay.
health department and MMDHD to educate everyone, so that perhaps as we see clients coming in, we have a better evaluation and tools that we can use to assess, where they're at. Because something that's always stuck with me in this training is not what's wrong with you, or what happened to you.
Exactly.
What happened to you. It was a proud moment yesterday when I was speaking with Molly to a community partner, and Molly said, well, Wendy always says it's not what happened. I was like, yes, I've said it enough.
Good.
So just trying to reframe our thought process as well, and not judge.
And I think it's really important that you said that you're gonna have a training for the
Yes.
entire staff,
Yes.
from somebody who may be answering the phones and just thinking they're taking a message, but then they're actually talking to someone who's upset about, something that had happened that maybe triggered something from the past, or.
Because the
and just
issue's not
knowing.
the issue.
Right, right.
Well,
exactly.
and it's not only our clients, right? So it's
It's
our
us.
coworkers too.
Yeah.
So
I'm getting to that.
anyone who's
But you're right, anyone that you encounter,
Yeah.
right? It's not necessarily
Yeah.
just a client.
right.
Right. Yep. How about anybody on the phone? Do you guys do some trauma-informed practice?
We were just talking about that, and I think it's really sort of interwoven in everything we do.
I would also recommend, if you guys haven't done it yet, to watch that movie, Resilience. It's nice to go to the screening because you're with, members of the community, and I think a lot of times they're actually trying to spread it throughout the entire community and not just one organization. So, all right. On the back side of that handout, it's just showing some examples of what other organizations have done. So you can take a look at that. And then the next handout is just kind of a little bit more of the same thing, just in an infographic. So I'll let you just go ahead and look over that. But the last piece is encouraging staff wellness in trauma-informed organizations. And so I think probably, I would say 10 years ago or so, I had went to a presentation, and they were calling it compassion fatigue. And so I was working more directly with people, and they would tell you that if you were working with people who were having all of these issues going on, that you could get burnt out from it. Now I think they're calling it secondary traumatic stress. And it's just from, hearing of other people's stories and consistently dealing with that. And then also you having your own ACEs. And so now you kind of know whether or not that might be affecting you, or maybe triggering some of those things that you had dealt with in your own life. And this handout kind of talks about maybe what your organization can do to help with some of these things. And they talk about encouraging and incentivizing self-care activities, things like counseling, meditation, exercise, and healthy eating. And then providing trainings that create awareness of chronic emotional stress and the importance of self-care. So, again, are there anything that you can think of that you did in your organization that maybe has helped with some of this? And if you can't think of anything, maybe we should start be thinking of those things also. And I think that's about it as far as what I have. I know it's kind of just an overview, and I know it's kind of a hot topic right now, so you may have already been hearing about it, but I encourage everyone to learn more. Any questions? Comments?
I kind of wanted to connect it back to like what we do. Not really, maybe a question for everyone, but like how does this inform how you interact with your clients? I'm just wondering how you think about trauma or clients in their past, or if you do that at all in their childhood. I mean, you're working with adults, and probably the majority of our clients have high ACEs scores. So how does it inform your work?
Well, just on Monday, I lived with significant trauma, and I treat my clients the way that I want to be treated. Or that how I need to be treated.
So how is that? Can you like give some concrete examples? I mean, I know obviously none of us are going to yell at or swear at or hit our clients. So, but what are some examples of that?
I don't really pay attention to myself, I guess, but just things that I've heard from when I've been job shadowed is that how calm I am and how I listen. And I just had one, and she said to me, she was such in awe. She's like, because I was meeting with a client who was diagnosed with paranoid schizophrenia, and he would keep interrupting me. And she's like, I was just so impressed with how you dealt with being interrupted. How calm you were about it.
Yeah, I think it's interesting, Caitlin, because you say like we wouldn't hit or scream or punch at any of our clients, but they may swear at us, and and how you're able to handle that, and just think back to everything that they've been going through, and the issue is not the issue. And being able to deal with it in a calm manner and accepting of what's going on is huge.
I think the importance of follow through and keeping your word is really key to this kind of work, because with ACEs you don't have a lot of stability in your past. So I've had clients tell me that I'm just the one that keeps them in line as far as calling them. Have you done this yet? Have you done this yet? So just the fact that I'm there to not only pay attention to what's going on, but to make sure that the client is capable of following through by themselves.
I think it's a really good point, especially probably many of them that haven't had that their whole lives, knowing that there would be somebody who's like, when they say they're going to call and remind them of something, they're actually doing it. And that's really important to continue in your work.
I think what was encouraging for me on perhaps more of a policy level too, that impacts us every day, is Medicaid and the health plans are involved in ACEs, getting people trained. Can they please see what they need to pay for? You know, we're down to sustainability again, right?
Right.
So, you know, can we get them to understand that if we want to impact these little kids when we're working with the parents, they're on your health plan too. Let it, you know, that it does equate to long-term cost benefit over the lifespan of that child, as well as getting that parent on track. So I'm hoping that their interest in getting more information on this and forming the statewide committee will then lead to policy change to sustain what we're doing, to have a direct impact on this every day.
Exactly. One thing I didn't mention also was getting these families connected to things like the home visiting programs, where they can maybe learn some of these protective factors. And it would be really nice if that was something. And I know, like, we've had the opportunity through one of the health plans to get reimbursed for doing that on just kind of a trial. But something like that, I think, would be a great reimbursable thing that would be worthwhile to them. Anybody else on the phone? No? Okay.
Nothing else? Okay.
Okay.
Thank you. Thanks, Kristen. All right. What time is it? So we completed another quarter. So I'm going to share the quarterly report data, which I did share with the agencies, but I don't know if it's been passed down to the CHWs, and I can email this out to everybody. Okay. All right, so this quarter, July through September, looks very similar to other quarters. So, but the good thing is we're on a steady increase in clients being referred. So I think last quarter we had like a little under 400 clients referred, and this quarter may be difficult to see, but we got 432 referrals this quarter. And so we had a total of 450 active clients, which means that they were, their status was enrolled. So that's a lot of clients that we've touched. And then this is the breakdown by community health worker. Everyone had between 30 to 50 clients on their caseload active during the quarter. So not all at once, probably, maybe, but through the whole quarter. And then again, this quarter we had, this is the number of referrals by referral source. So again, primary care physician practices. Usually we don't get the referral directly from the doctor. It's from a nurse case manager or social worker at a practice. So we got most of our referrals from primary doctor, health plan, and hospital. And then community health workers were right up there as number 4.
Question, what's the difference between hospital and ED?
The hospital is inpatient, although I think there is some overlap where people will just click hospital. So, yeah, good point. The main reason for referral, so if you've ever filled out the referral form online, it forces you to choose a main reason for referral. And overwhelmingly, we have access to community resources was the number 1 reason for referral, followed by actually pregnancy and postpartum support, because we had the MIHP project this last quarter. And actually in this quarter I included the McLaren project, special projects, in these numbers. Client contacts, very similar to past quarters. We're more successful with our in-person client contacts than with our phone contacts. About 84% successful with in-person. And then I did separate out, I took out the left message line there because they may have called back, but I did still only count the successful ones as successful. So about 52% successful with the phone calls and reaching the person you're trying to reach. Now to pathways. Health education pathways, for 55 clients, we did 65 health education pathways. And the most were for depression and anxiety, which coincides with the number of clients who say that they have depression and anxiety. Our medical referral pathways, medication assessment was the most. We had the most pathways for medication assessment, but for referrals, dental, surprisingly, we had the most referrals for dental, but the number of, I think the ratio of goal not met to goal met was a little higher for that one, or lower for that one. Goal met to goal not met. Transportation too, there's a lot of preventive resources for that one, which is the red. Can you guys even see this? So the good thing is, I think if you remember a few quarters ago, we had talked about we were seeing a lot of the goal not met, and this was before we kind of added resource provided, result unknown. And I added up all the number of pathways that were closed, goal met, and all other pathways that were closed with any other reason. And we do still have like a 65% rate of closing goal met. So that's great. We have, we're more likely to close a goal as goal met. Yeah. Did you have a question? Oh.
Just was following along.
Just saying.
Yeah.
Amen. So that is a good thing. And then social service pathways, we had food and housing as the number 1 and 2 top social service pathways open or closed during the quarter. But the number of housing pathways closed, goal not met. I don't think that's a surprise, but that is one of the harder pathways to close successfully. So, and then again, this is the chronic conditions, self-reported. And again, anxiety and depression is the number one self-reported chronic condition, followed by back pain and arthritis. Then I also separated out the McLaren clients because I thought this was interesting and I wanted you to see this. Because I'm starting to send the quarterly report to McLaren directly just for their members. It will be on here. So,
Has so few, I think. I don't know.
wait, what?
I was gonna say.
Montcalm didn't have
so
any,
few McLaren, if she even had.
she
it
didn't
in
have any that quarter.
That's what I was
That makes sense.
thinking, yeah.
Yeah. So the interesting thing I think about this was that we tracked over 13,000 minutes for so many clients. I can't remember. It was like 130 some clients, and that averaged out to about 98 minutes per client. So when we hear McLaren saying that they want us to, that they're restricting us or giving us 2 hours and that doesn't seem like enough time, I don't know if they're looking at how much time we're tracking for each client, but I just thought that was interesting because I thought it would be higher. Anyway, so that was interesting to me. We had 96 active or enrolled McLaren clients during the quarter, 99 referred McLaren clients during the quarter.
I think with that too, the reason the average is so low is because it's hard to contact the clients. A lot of them have moved and changed their phone numbers, and if we're getting them from the health plan has tried to contact them.
Right.
But then we're sent out trying to find them.
Right, exactly, yeah.
That
So additionally, yeah, I think that's right. And I know, this includes all the ones that were not even enrolled. So I was looking and there were a few that had 6 minutes tracked because they were contacted and they declined services. So that's 6 minutes. It was just a short call and then they were closed. But, oops.
I have a handful that average around 200.
Right, yeah. So I was gonna put the mode of the number, or what the highest was 600 minutes, which is about 10 hours. So for McLaren, our referral sources, we had 49 referrals from the health plan, which obviously is from McLaren Health Plan, and that was when we had those MIHP referrals, and then the rest were from, PCP, CHW, etc. The main reason, this coincides with the MIHP clients as well. Pregnancy and postpartum support and access to community resources were the highest reason for referral. And then for contacts, this is the slide I thought was most interesting. We are not much, we're about 10% less successful contacting our McLaren clients in terms of phone calls and in-person contacts. So I don't know if you can see that, but I think we were about 88% successful total for all clients, 84%, and for in-person contacts, 73% with our McLaren clients. And then for phone calls, 45, and I think it was 53 or 52. There you go. So we knew that. I mean, I think we had that was a feeling that we had. The amount of time between receiving the referral and then getting the authorization, I think, is a deterrent. I think also there's, I have a suspicion that there's a slight resistance when you see McLaren, when our CHWs see McLaren, and it's a lot of work to have to work with a McLaren client because you have to request more time. You're restricted by the authorization and the amount of time you can work with them. So I don't know if that's conscious or not. But I think that it's just harder to reach those members. And when they do send them over from the health plan, they have the state data, so it's not always accurate. And clients don't know that they're being contacted. And when they hear, "Hi, I'm so-and-so from Pathways, and I got your information from your health plan," they say, "What the hell are you doing calling me?" So I think that they're just a different breed of client. And then these are our pathways. So the health education pathways, we had 9 total for 7 clients. No anxiety ones, which I thought was interesting, but 3 depression. Did someone have a question on the phone?
Yeah, Caitlin,
Yeah.
if you're meeting a client, like the provider, is that contact under, is that under client or provider?
That would, if you're meeting the client, it would be in person with the client contact in person.
Okay. I
Okay.
mean, that's what I've been charging, but I would need to, yeah. that's what I
Yeah.
need to make sure. You can put it on the provider contact. Okay.
Right.
Thanks.
Nope, no problem. Medical referral pathways for our clients. The interesting that medical transportation, that red is the goal not met, and that's the highest one here. But that one, we had only 1 goal met for medical transportation, and we had 10 that either 4 of them were research provided result unknown and 6 were goal not met, which is just interesting.
Was that because we we added the result of healthcare benefit education? Because I could see that some of the goal not met would be the benefit education. They
Right.
didn't use it, but they knew
Well,
about it.
we had the preventive wait. Actually, that's preventive resource. I have preventive resource and goal not met as the same color in here for some reason. But I think that's preventive resource. Sorry, I'll have to fix that. Okay. That's weird. Social service pathway looks similar. I mean, there's just fewer goal met pathways closed because I think because we're restricted by time to get them connected. And then chronic conditions looks similar. Anxiety and depression is the top. Back pain is next. And that's it. So that's the quarterly report. And we do have a new fun way that we are sharing some of the data. Do you want to share it? Do you want me to share it?
Yeah. I emailed it to you.
Yeah.
So this is going to be our quarterly newsletter, and we haven't set it out just yet. I think it's probably going to go out either today or tomorrow.
Can I get it zoomed? There we go.
I think we're going to keep the structure of it pretty much like it is right now. So it will start out with like an update from Lori. This is kind of her little inaugural, however you say it, update here. giving a brief detail about each one of the programs that the hub works with.
This is a side note, but my last name's spelled wrong in there.
Oh,
Uh-oh.
good. See, glad we didn't send it out yet. Just that. And then this is the quarterly overview that has, it's a cool infographic that Caitlin created that has just bits and pieces from, I think, the quarterly report, correct?
Yeah.
So I think hopefully we can get her to continue to do that. It's just kind of like a PDF right here, but if you wanted to get more into detail with it, there's a link below it that will go to a more interactive infographic.
Who else is being distributed to?
We will send it to our referral sources and other, mostly it's our referral sources and then you guys. And it can be forwarded and people can sign up to get it.
So there's that with,
Oh,
oh, go ahead.
hello.
Yep.
This is Sue. I like the newsletter. We are wondering if we could take a look at it before it goes at least to our referral sources, because we're thinking maybe it would be appropriate to add Ottawa-related information to our referral sources.
Yeah, we can talk about it.
So, yeah, I guess if we could just talk about it and have a better understanding of it, that would be awesome.
Sure.
Thanks.
And then we'll have a CHW spotlight each time.
We have Shelly in there
Shelley.
this time.
And there's already questions that we developed, so we'll send the questions out to whoever is chosen each quarter. And then a referral source spotlight.
And if you guys want to nominate a referral source or a community health worker for next quarter, you can.
And then we'll pick out of some of the success stories. So I think this time we included 2.
This is Ricky's. And then this one is Aaliyah's. And Shelly has one up above.
And then we just have everyone's logos as partners in this work. And then like us on Facebook if you haven't liked Care Hub on Facebook yet.
All right. So we'll send that out.
With the purple stone.
Yeah. Oh yeah, Newtown. Okay.
Sounds like a band.
It's just teal.
Yeah.
Any questions about that or comments?
I like the infographic.
It's cool.
It was fun to make. Okay.
Good at it.
Thanks. All right. We can take a break, but I only have a few more things left, and then we can finish up. So, would you mind if we just go another 20 minutes or so? Is anyone dying to get outside? Okay, so a couple things. One is we have a success story that we wanted to share, and it was that Molly has gotten her first SOAR application approved.
We got
2. Oh, see, this is so. The last time I talked to Wendy, it was just 1, but in the last week,
Their
you've got
award letters on the same day.
awesome.
One was for Clinton County, one was for Montcalm County. The first one was approved after 3 months. 3 months, yep. And the second one was 2 months.
Wow,
And the first one is getting nearly $7,000 in back pay.
wow.
And she has a history of homelessness, and lives in her vehicle and sits outside of gas stations
and
Yay.
get her situated. So yeah, pretty cool stuff.
That's awesome. So, round of applause for Molly.
So Ottawa, I know you're all being trained in this. I know that it's time consuming and so are each application that you're gonna do, but it's worth it. Totally worth it.
Yeah. So,
But we're talking about it, it'll be so worth it.
yeah,
Yeah.
it is. It is. And 2 months is like nothing
Unheard of.
compared to
2
what you
years.
guys are used to. Yeah.
More.
Yeah,
Yeah.
more.
Yeah.
So very cool.
Did we talk about adding a pathway for specifically for SOAR?
No?
Maybe we need to do that. Do you guys want to be tracking it when it's a SOAR application?
That would be beneficial.
Because it would just be a social service pathway, but we would just call it a SOAR
I've just been
pathway.
putting under financial assistance,
Yeah.
but yeah, I think that would be good to be able to track it better.
Okay. I can do that.
Give it credit for all the work
Yeah.
that goes into that.
Yeah, it's a lot.
It's a lot of time. Yeah.
Hello.
Hi.
Hi, Caitlin. We were just discussing over here at Adela maybe Social Security, like applying for benefits, having its own pathway. Or would that be would you put that under financial assistance?
Depends on what benefit it is. So if it's like food or, you know, before we were putting it either under legal or social or financial.
Okay, thank you.
Yeah. Okay, so does anyone else have any success stories? I know we don't usually touch on that, but I thought Ricky's back. Oh, okay. So can I share about Barry Eaton? Can I share your story?
Sure.
Not anti-success story. So Chelsea, I don't know if you guys know this, but Chelsea's been out since it's only been a month,
No, it's been longer. Yeah.
like mid-September probably.
Extended period of time.
She's been gone a while, and she's having some health issues, basically. So it's been unexpected. We thought she would be back, but now it seems like it's going to be a little more long-term. So we have a card?
Yeah.
We do have a card for her that we'll be passing around, just sending her well wishes, because it's just hard.
She wants to be back.
Yeah. So Ricky's been but definitely taking on Chelsea's caseload and her own caseload. So she's overloaded. And then she fell and broke both of her arms. So 2 weeks ago,
Elbows.
both elbows. And we thought,
Both elbows.
How
Yes.
did you, oh my goodness. Just to let you
No,
know.
I landed like this on my way forward and tripped.
oh,
Yeah, so they call that a radial head fracture, so the radius right at the elbow
on
joint.
both sides.
Well, there's some question now because apparently that fracture doesn't show up for some time in X-ray. But initially they said yes, both are potentially fractured. It still feels that way,
Oh, yeah.
but it's apparently not treated with a cast or anything along those lines. It's just power through it.
Yeah, so she was out for a week and a half. We thought she was going to be out for longer, so we were freaking out a little bit, but luckily her doctor gave her the okay to come back to work.
Which is today's my first day back, so
So welcome back.
thanks.
And
Take care of yourself.
yeah,
Talk about self-care, right?
Yeah.
yes.
Trying to take it easy.
So, and be thinking about Chelsea and Ricky, because she's having to kind of take on more than one person's caseload right now. And Megan, too, is really helping with the this kind of period of question marks. So,
Caitlin,
yeah.
this, this might be a really good, opportunity to just, we're interested to hear how other agencies are handling waitlisting.
Waitlisting? Well, we had a wait list, or we have a wait list for Berry County, Berry and Eaton County, because Ricky has like 60 clients or so.
Down to 60 now.
She started
Started with 82.
And that is too many clients. So, so we started waitlisting, but then after the incident with her fall, we have started to deny some clients for Berry Eaton because they're just going to be waiting for months probably at this point. There's, I don't even,
About 18 on the wait list.
yeah,
Yeah,
so,
just right before I hurt myself. So I
Then,
keeping some.
how do you decide who you deny and who you don't?
right now we're just denying blanket everybody, except I sent you an email, but we might consider McLaren clients just because of the funding source, but maybe not. But with Ottawa and with other counties, I know Gratiot, Montcalm, has Clinton ever had a wait list?
At one time.
Yeah, you
before we
guys
had
have
Angie, yeah.
all had a wait list. Ingham has had a wait list before. So when CHWs are feeling overwhelmed, and most of our counties have one community health worker, so that's easy to get overwhelmed. And I know Ottawa, when Ingham had more than one community health worker, we would sometimes just take one community health worker out of the rotation if they were feeling overwhelmed. But if all 5 CHWs are kind of at capacity, then we would just start putting people on a wait list. And then as community health workers are feeling ready to take on clients, we would start putting them on people's on caseloads. And we do have a referral confirmation that goes out to our referral sources saying, thank you for the referral. Due to capacity or something like that, do you know, I don't even remember what it says, but it says something about a wait list. It'll be a couple weeks before, or several weeks before they're contacted. We'll let you know when they're assigned a community health worker.
And is that something that's triggered through the referral link?
The what?
I mean, is that the similar to what's triggered when a referral is made, the pop-up that comes back, or the email?
Oh no, we do it at the hub, on the hub level. We do it manually. It's the same as any referral confirmation that we do. We'll just send a different one instead of saying that they're assigned to so and so. Yeah.
So we have to, or Sue would have to tell you, like, oh, the CSW is so overwhelmed, blah, 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 and we just put up on wait list kind of thing.
Right. Yep. And it can be like a 2-week thing, or it can be months. Depends on where you guys are and.
On average,
How are you
people
feeling?
have felt overwhelmed at around 60, right?
No.
Even it depends. Yeah.
Depends on what the needs are.
Depends
yeah.
on the needs.
Sometimes at 40 or 45, people are feeling overwhelmed.
Yeah.
Depending on the needs of their client at that time. So I never
Right.
really set
There's no
like
yeah.
a caseload that it had to be at before I put
Right.
the wait list on. I kind of gauged how the CHW was feeling and the needs of the clients at that time.
Yeah. I mean, at 60 clients, I would be surprised if you were not
Correct. I would agree.
overwhelmed. 60 is like a ton. 80 is too many.
Yeah.
So, yeah, so there's no number. It's just
I
the
just meant on average.
Yeah.
That's kind of when we saw it happen.
60 is like red,
Yeah,
you know,
like
flag.
40, 45 is when I started evaluating how are you feeling,
Yeah.
how do you think things are going, right? Are you able to keep up on? Yeah.
So now that you know that everyone has done it, everyone's
okay.
had a wait list. We can talk after this meeting, Sue, if you want, and we can talk about what you guys need. Does that work? She hung up. Are you there, Sue?
Sorry, yeah. we didn't catch on.
So we can talk after the meeting about what you guys need. Does that work?
Okay. And we're in the process of hiring another community health worker, but it obviously would be a few weeks before they're in.
Yeah. Okay.
We've made the decision at Barry Eaton at this point for our wait list to like prioritize and get the higher risk people seen first. So again, like we were talking about how it really stinks for the person who the referral source didn't do a very thorough referral. So if they don't put much information on there, they could be higher risk. But if I've got a good paragraph and I'm getting a snapshot of the other person that was referred after them, I'm gonna go.
I love
With
getting
them.
referrals from case managers because I get a paragraph.
Right.
Yeah.
But it's all you have to go on.
Right.
So you gotta choose your criteria somehow, right? And
Yeah.
best judgment you can with what you've got in front of you. So I'm the same way. You don't give me much information, but I got somebody who has all these high needs identified specifically.
Right.
I'm gonna choose them.
Yeah.
Right. Yes. So, yeah, we can talk about that, but it's not a problem. All right, any other questions about caseload, wait lists, anything else I add? Okay, we got a few new things to talk about. Let me get it up here. We have a new update to the procedures manual finally. I've been updating it, but I haven't shared it yet because it's just constantly being updated and it's never going to be ready. So we did upload it to the resources tab on a set. So now you can access its version 4. But we got an email so Ottawa was looking at the use of pathways list, which is the Appendix A in the procedures manual.
Is that what you print? Is this appendix A? There aren't enough copies, so just so I know what to get.
Oh, here.
No,
I have mine.
Thanks.
I have mine on the computer. So they were being new and not being involved in a lot of our conversations we've had around when do you use this pathway, what do we do for this referral source, like when I make a referral for this, where does this fit? We've had those conversations for 4 years, and mostly Mid-Michigan have been the ones involved in that conversation. And if Chelsea were here, she was involved too. So, so they were kind of going through and added specific examples for some of these pathways, where to put what. And then I went through it and made sure that everything looked good, and it did. So we added some possibly helpful little tidbits into this description. So I did highlight them in yellow. So like for education, there's the new telehealth information, so that would be under the emergency department, education. I did add for other education that this is chronic condition related only, so it's not when you provide education about how to use their phone or how to access a service. This is related to a specific chronic condition or something that's related to a chronic condition. So just highlighting that. And also try to avoid that because, you know, we don't want to use the other. It's harder to track what you're doing in other. Medical vision, assist with glasses, etc. One thing I do want to point out with medical referral pathways, all the descriptions say can assist with preparation for visit. So I've seen in some ways people will use that education other pathway as a way to say, well, we educated them on how to talk to their provider about their medications or, you know, stuff like that. But that's actually part of the medical referral pathway. So that education piece may fit into that pathway. So keep that in mind. Some of these are a little more obvious. Hearing, assisting with hearing aids. Pharmacy, when you connect the client to get their prescriptions delivered, that would be a medical referral pharmacy. It's not social service pharmacy. Phone, getting a phone. This is a question that we get all the time, and I've added it to our frequently asked questions piece of the procedures manual. When you help a client get a cell phone, a government cell phone or other, that is not a utilities pathway. That is a social service family assistance pathway.
I've been using household items,
Okay,
all along.
so it's family assistance. So this is why it's a frequently asked question. It's family assistance.
But it's good to spell out these examples.
Yeah, I think so too.
That gives you more consistency in the data when
Yeah.
you're pulling stuff, so.
Yes. Financial assistance, they really spelled this out. I'm giving credit to Ottawa because they really went through and talked about all this stuff that they went through here or use this pathway for. Food, healthy home, household items,
Now, I noticed that car insurance is in both financial assistance and insurance assistance.
oh. Car insurance would be under insurance, social service insurance. Thank you for pointing that out. Car payment. Can I delete that? No. Okay. I'll fix that in the procedures manual.
You said insurance assistant?
Yep, it's social service insurance. Employment, medication assistance. So I really like these, getting a pill box, medication reminders, you know, helping them get that app on your phone to help them remember to take their medications, you know, all that stuff that you help, not just paying for medications, but taking their medication. So that's helpful. Obtain ID. Yeah.
I think we were being, so they're saying actually obtaining the car insurance versus
Getting
paying
it.
for the car insurance. I think that was the
Okay.
correct there.
Also,
Paying, so if they have car insurance but they can't pay it, or they need help paying it, finding financial assistance to pay their car insurance. Okay.
Right.
That makes sense.
I'll clarify that so that's more clear.
Or any kind of insurance, yeah.
Okay.
It's just what insurance payment, like is a car thing.
Yeah. Interpretation assistant. So, I like this, getting Braille, stuff in Braille for our clients who have vision impairment, information in multiple languages. That depends. So, If you're getting like health education in a different language, you wouldn't open the health education pathway and the interpretation pathway. It would just be the health education pathway, but I guess it would depend on what, if you're like referring them to a service to help get their mail read or translated or interpreted for them in a different language, stuff like that. I don't know if that kind of service exists, but
If we could talk a little bit more about that, I think that at least what we're encountering by whether it's using a language line or getting someone that can sign language, it's for a greater purpose than health education. So in that case, would there be both pathways?
well, I guess it would depend on the situation. Do you have an?
Well, the situation, looks like if we have a client, they're both hard of hearing, I only can talk to them using ASL. So whether I either call and say, hi, you have an appointment at 5 o'clock, I need an interpretation for that.
Right, and that would be a perfect time to use it. I'm talking about like paper, like when you're printing out something off the internet about diabetes, if you print it out in Spanish or in Vietnamese, that is not an interpretation pathway, if that makes sense. But if you're using an interpreter or you're using a service to help interpret, that would be a separate pathway.
Okay.
Does that make sense?
Yep.
Okay. Utilities assistance, only home utilities related. So anything that can get you evicted if you don't pay it is that utilities pathway. And that's it for this. If you come up with other examples, I like these like specific examples and having them on here. I think that this was really helpful, and it's good to have everyone on the same page. So thank you very much, Ottawa, for going through and doing that.
You're welcome. Thanks for being accessible.
Yeah. The other thing that I shared with the group here was 3 new frequently asked questions that I've added. I haven't really updated this frequently asked questions section of the procedures manual in a long time. So like some of it still says stuff about points that we used to get back in when we had my pathways, which like only you 3 remember, but so I do have to update some of it, but I added 3. One of them is that phone pathway, which pathway do we use for the phone assistance, and that one is the family assistance. Ottawa asked a question about what the difference is between medical referral, family assistance, and or not family assistance, family planning. I wrote this wrong. Medical referral, family planning, and the family planning pathway. Which, did you guys know there were 2? I don't think anyone's ever used the medical referral family planning, or even really the family planning. I never see that. But the difference is that the medical referral family planning is to assist the client access a provider, so getting them to the appointment, helping them make the appointment, and connecting to the appointment. So if you're sending them to like Planned Parenthood or to their own provider for family planning assistance, that would be, or an OB, that would be medical referral family planning. The family planning pathway is to assist the client in choosing a family planning method. So, or preventing their family from expanding. So, part of that pathway, if you remember, if you've ever filled it out, because it's very rarely used, part of it is the client choose it, they make an appointment, they look at a list of potential family planning methods. They have, birth control, pill, all the different methods. And they decide which one they choose, and then 30 days later, you follow up and ask, are you happy with that? If not, then you help them follow up with their provider. So it's more about choosing a method than it is about connecting to and being happy with their method of family planning. Does that make sense?
So you could potentially open both, if you're providing them the sheet, and they say, I want an IUD.
Yeah.
And then you say, okay, let's call and make an appointment, so then you make the appointment, right?
And that would be, medical referral family planning.
Okay.
Yeah.
And then follow up to see
Yep.
what's.
Yes.
Okay.
Yes. So that was a good question, because I honestly had never really thought about having two different ones.
So when you show them a list, if you open up this family planning pathway and you show them a list, and they have questions about it, well, it's out of our scope of practice to
Right.
direct them
So
either way.
I think in the pathway, and I'm going to be honest, I'm not like super familiar with it because we rarely use it, but I think it is more, you talk about, you give them some education about the importance of family planning, but it's not, here's the difference between this type of estrogen
But I
pill
know that
and
if we're showing them a list,
what you do is have them go to their doctor and talk about what kind of family planning methods they're interested in, and then they come back and then they let you know what they've chosen and you select those.
okay.
So
So just that it's reported what they actually
Yeah.
chose.
Mhm. Yeah. So
We can't understand what's being said.
oh, sorry.
One, if it's more appropriate to make it an education standpoint.
The part of it is education about the importance of family planning. But you're not educating on the difference between, different types of methods. You are referring them to their doctor, and then the doctor's helping them make the decision, and then they report back then you follow up with the client, ask what they chose, and then you follow up, I think it's 30 days later, and ask if they're still happy with that, if they have any questions, and if they do, you encourage them to go back to their provider and talk to them about them.
It's more of an assessment tool than, or a providing assistance tool.
Right. Mm-hmm. Yeah. Does that make sense to you guys on the phone?
Yeah.
Okay. The last question that came up this quarter just recently was, now that we've changed the pregnancy pathways, we got a question from Shelley about how to close the third trimester pathway. All of this client's other pathways were completed. She didn't have any other needs. She's not a priority member. So, but she hasn't completed all of her third trimester appointments yet, but she's well on her way. So how do we close that pathway? And it didn't make sense for her to keep it open and continue to follow up with the client throughout the third trimester. So we recommended closing that pathway with the outcome resource provided result unknown. So this is for the non-priority clients. So if they're priority and it's a priority approved pathway, you would still continue to follow up with the client about their appointments so that you can close that goal met, because then you get payment for it. But if they have no other needs, they're not a priority member, then it's similar to the housing pathway where you wouldn't keep them open while they're on a wait list. So resource provided result unknown was the outcome. So if that comes up again, you know the answer. Any questions? So I'm going to try to track the questions that you guys ask, because I think we do have more frequently asked questions that I answer, but then I don't write it down and then I forget what I answered. So this is helpful for me to keep track of that. And so I'm not giving you multiple different answers. So, any other questions? All right. One thing I wanted to bring up, I have 2 more items. One thing is, for those of you who have priority members, I have gotten no priority authorization requests in about 2 weeks. So just wanted to bring that up and remind you to be looking at your new priority members and whether they fit into those like very narrow guidelines. But I just wanted to bring that up. And then yeah.
Regarding that, are you suggesting we do everything we can to find a priority pathway?
If you want payment, yeah. Yes. I mean, within reason, you're still trying to follow the model, but yeah, if there's some solution, yes. But obviously, if you guys are thinking about it and just nobody fits in within those guidelines, then it's just a problem with their guidelines.
Or you can try, you can ask, and they can say no.
Right.
I've done that a couple times.
Yeah, I think that I don't know if you guys heard that, but Ricky just said you can try and ask, and I agree with that, but I would rather ask too many times and get denials from them than to not ask and not know if they were going to deny or not.
What is it that it has to be in those, criteria?
Yeah, so they do have to try, you have to try and fit them into the criteria, which I know is narrow. But I just wanted to bring it up so that you're thinking about it, which, you probably already are, but I just wanted to bring it up. And then if you have questions, if you have questions about it, let me know. The last thing, oh, go ahead.
So if it is, how many times would you say would be considered frequent for eating?
What? What did you say?
For ED usage,
How many times do you think is enough for a frequent use of this ED?
We're saying 5 or more. ED.
I can. Okay.
Okay. Okay. So the last thing is to talk about the December meeting. For those of you who have not been with us in the past December, we usually just have a fun celebration, end of the year type thing. So we've done white elephant gift exchanges. We're thinking that we would do one with the whole, with Ottawa in person, in Portland probably again, either at that bank or somewhere else. But I just wanted, does anyone have any ideas? Do we want to do a white elephant or other?
I like that tradition.
White elephant, for those, do you guys know what a white elephant is? Do you guys?
Yeah, we do.
Okay. All right. So would anyone be opposed to doing white elephant?
Well, if you don't want to, then you just don't get a gift.
Yeah.
I mean, that's easy. I mean, if you choose not to.
Right.
For those that do are draw the number and blah, 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 so.
Okay. So we can do that, and we'll try to figure out location, do we want to do, I'll try to find a place that allows food too. I don't know if that bank, I think the bank allows us to bring food in. The other place we were looking at was the VFW in Portland. And they charge for kitchen use, but for nonprofits it's free to rent the facility, but we can't use the kitchen. So I have to see if we can at least just bring in some food, because we want to eat, right? So
Do the wagon wheel and then like do pizza.
what's the wagon wheel?
Bowling alley, restaurant.
A restaurant bowling
Yeah,
alley?
it has like a little banquet room.
Oh. Well, we'll talk about it. I just wanted to bring that up so that you look forward to something in the next month.
Do you wanna do a sign up for food then, Caitlin, and just send it out?
Yeah,
However.
I think I'll do that. Yeah. It's optional. If you don't want to bring something, you don't have to, but we will do that. Maybe Chelsea can come for that. All right, that's it. And it's still going to be that first Wednesday. Does anyone have a problem with that date?
No,
if we-
that's fine.
You can count on Ottawa being there.
Yay.
So, unless the weather's bad.
Yeah, hopefully it doesn't snow. All right.
Maybe,
Huh?
maybe can we just make it a little later than our usual time?
A little later?
Yeah, just because if we have to drive and, get our kids off to school or whatever, and then we're not staying and.
I think that's
And go
reasonable.
until-
Yeah. Sure. So like 10? 10 to 12?
Yeah. 10 to 12, and
that
then
works.
do a lunch right after, I don't know, whatever works for you guys.
All right. We'll send out an email and with all the details, and I'll send out a list, sign up list. Okay. Molly had
Sounds good.
something to share.
Yeah, I
Yeah.
was just noticing, and I don't mean to end on a negative note, but I was noticing, like, with
We
trying to
can't hear that very well.
Can you talk louder?
Oh, okay. I was noticing with trying to get sustainability and with getting funding from the health plans, that I feel like we're going further and further away from our evidence-based model. And I feel like that's why we're not seeing the outcomes that we originally did with the evidence-based model.
Mm-hmm.
And what I mean by that is, it's on our mind to be conscious of the time used with these clients. And before, you guys don't know this, but we had an assessment that had to be done monthly.
Mm-hmm.
And it was a follow-up checklist. And even if we didn't identify any additional need at that time, it was still building rapport with the client. And I feel like we've fallen away from that. And sure, I have some successes with my clients that are very needy and have a lot of things that need to be accomplished. But the way that this has been set up, I told Angie an example, like, I'm not even getting that personal relationship with the client anymore. I'm meeting their very minimal basic needs. They're not gonna give a damn about any education I give them about anxiety. They're just not. So yeah, I've been noticing that in the work. And I wanted to.
So this is even with your non-McLaren clients, or only is this with just the
I
McLaren
have
clients?
more of a relationship with my non-McLaren clients, sure, but the majority of my clients are McLaren clients.
Right. Yeah. I will say Robin, our executive director, and Lori went to McLaren and talked to them about going to an outcomes-based model similar to Priority, and they said no. So we're trying. And I acknowledge what you say, and I agree.
I'm sure that you've noticed that as well. I just wanted you to see from my perspective. What I've
Yeah.
been noticing in my work as well.
I know, and one of the slides that Kristen brought up with that last slide about emotional stress and how there's like a loss of creativity and exhaustion and cynicism. I feel like that's happening with our community health workers, and I don't know. I mean, I can say that we're trying to fix it,
I know you are.
but all I can say is that I agree and acknowledge your feeling of frustration, and I think that you're not the only one who feels that way.
Right. And, I'm not 100% happy with my job, that's not what I'm saying. I know that I still do good quality work.
Yeah.
It's just, I know the engagement rate is slipping
Mm-hmm.
because, we're falling away from the model.
Yep.
That's all that I'm saying.
Yeah.
No, I
Yeah.
think it's a good observation, you're right. Can we do anything about it today? No, but I think it's a good observation is we're looking at all the data from the last quarter, contacts and, completed, goals and et cetera,
Yeah.
that it's a reflection, I think.
I do see, and maybe at the January or maybe February meeting, I'll look at the year. But I have seen that things have, compared to January last year, I think things have improved in terms of engagement, pathways closed complete or successfully. But compared to when we were under the grant, it's different.
It is.
And I will say too that, that there are attempts to change things at the state level. So we are doing things. We do see that it's not ideal, and then it's a problem. But changing the state or changing any sort of system, larger system, is just difficult.
Yeah.
So, it'll take a long time.
Right, and I'm just hoping, with this being said, I'm just hoping that one day we can maybe convince them to go back to the way that the evidence-based model initially ran.
Yeah. One thing that I've noticed is that, and this is just a small thing that maybe you haven't noticed, but I've seen it because I'm seeing all of the authorizations come through. They're authorizing pretty much everybody.
Yeah.
They are authorizing usually 3 hours now instead of 2 right away. So
Small steps.
not a huge difference, but it's like moving in the right direction.
Yeah.
I've seen more approvals on my extension too. Like I think I have 780 minutes with somebody. So it's just small steps, like you said,
Yeah.
and taking into consideration that you really, really have to paint a picture of need, unfortunately,
Yeah.
when you fill out those
Well, what I'm
requests.
saying is like, yeah, I haven't had any issue with them not approving time, but
It's
I'm
changed.
still not doing the work that I did before, so I'm not showing them
Right.
what actually worked in the past.
Yeah.
And
Yeah.
who knows if they would approve of that, me just going out and getting to know my client like I used to.
Right. Yeah.
Yeah, I'm not being negative, I'm just,
Realistic.
yeah, I'm a realist.
No, and thank you for bringing that up and feeling comfortable saying that.
Yeah. I know you guys are feeling it as well.
Yeah. It's not been a fun transition for anybody, so we're working on it.
I know, yeah.
Okay. Anything else?
I do
Yeah.
have one more thing.
Yeah.
This will be Angie's last meeting. She has decided to spread her wings and take on a new adventure, so I just want to thank her for her service with all of us here and what great work she's done in Clinton County and moving the whole Pathways program forward. So it'll be
are you going?
Thursday is your last day, West Virginia.
What?
Whoa, you really are.
Yeah, well, I wasn't kidding you.
She's really going. What are you gonna be?
But it's time to do something different.
What are you gonna do in West Virginia?
I got a job at the post office and with the janitorial service right now.
Awesome. Do you know anybody in West Virginia?
My girlfriend.
Oh, so she moved already?
Oh, she's from there.
Oh, okay.
This is something different for me. This is something different for
Hey,
me.
Caitlin,
Yeah.
we're only picking up about half of the conversation. I'm wondering, are you gonna do like minutes
Yeah.
for this meeting?
Well,
Great.
I have it. I'm recording it, so hopefully it's working. But
Oh, perfect. Okay.
yeah.
That's even better.
What? It's Angie's last day or last CHW meeting. So she won't be able to participate in the White Elephant, which I feel really bad for you for not being able to do that. But she's she's moving to West Virginia, so we will miss you a lot. Yeah. But that sounds like a great, exciting move.
Congratulations.
All right. Anything else? All right. Well, that's it for me. I'm gonna